Hello everyone. Today we'll be talking about apical impulses. So apical impulse is nothing but it is defined as the palpable pulsation of the left ventricle against the chest wall, which is usually located at the fifth intercostal space. So what does it means that it is the point of the maximal impulse in the chest wall where we feel the left ventricle apex. So supposing this is the chest wall, so the maximum impulses of the heart, which we felt. So usually that is the maximum impulse is felt at the apex of the heart, and that is why it is called as the apical impulse. And usually it lies in around the fifth intercostal space in midclavicular line. So now we should know that why that apical impulses occurs and in which phase does it occurs. So usually what happens during systole, that is the contraction phase of the heart, is that the blood is emptying from the heart. So the muscle will narrow here. So since it's contracting, the muscle should go more inside, more inside, and there should not be, then it means that the apex should be away from the chest wall. So, but it doesn't happen like that. In this, during systole only, that is during contraction phase only, the apex is felt at the chest wall. So why does it happens is that there is because of the arrangements of the fibers. So in heart, cardiac muscle or myocardium, there are three types of fibers, that is longitudinal fiber, the radial fiber and the circumferential fibers. And also the usually the longitudinal fibers are located outer and radial and circumferential fibers are located inside. So, why apex touches the chest wall during systole rather than during diastole? That's what we think because during diastole, the left ventricle is filled up with lot of blood, and we usually think that during this diastolic phase, the apex should go and touch to the chest wall, but it doesn't happen that way. Why is because it happens because of the spiral orientation of the myocardial fibers. The heart muscle fibers are arranged in a helical pattern, that is the spiral pattern. So whenever there is heart contraction, there are two types of fibers. One is the outer fibers and others are the inner fibers. So what happens is this inner fibers, which is located in the inner part of the myocardium, it moves inside. So this leads to the contraction of the heart and narrowing of the ventricular chamber. But when this occurs narrowing, there is rotation of the outside fiber in such a way that the apex will go outwards and goes more downwards toward the chest wall. So remaining part of the heart generally stays in constriction. However, the apex moves towards the chest wall and this is felt at the apex. Other mechanism is the longitudinal shortening of the left ventricle. So what happens is during the contraction, the subendocardial longitudinal fiber shortens the heart long axis. So this action causes the base of the heart to move upwards. So the base of the heart now starts moving upwards towards the root of the heart, and the apex remains there only. So this apex also just, fells against the chest wall, generating the palpable apical impulse. So there are various types of apical impulse. We will go through it one by one. Tapping type of apical impulse, which is seen in mitral stenosis, and it is nothing but is the loud first heart sound. So what do you mean by first heart sound is that S1 occurs due to a stiff, that is the closure of the mitral valve. In mitral stenosis, since the mitral valve is very much stenosed and fixed or calcified, there is stiff mitral valve, and whenever this closes, it produces a loud first heart sound. And this first heart sound is also palpable, and so that's how the palpable first heart sound is felt at the chest wall, and this is called as tapping apical impulse. Second is the hyperdynamic type of apical impulse. Hyperdynamic means that the volume is very much high. But so what is means that in this apical impulse, the volume inside the heart is very much larger. So there is a forceful, because of the large amount of volume, the apical impulse will be very much forceful. But the duration of the apical impulse remains the same because there is no obstruction to the flow anywhere. The blood will empty from the ventricle as similar to the normal beating time. So the duration will be normal. That is usually the apical impulse is usually felt less than one third of the systole. So total duration of the systole, how much is there? Less than one third will be the apical impulse time. So in this hyperdynamic time, the apex pulse will be very much forceful, but it is of normal duration. Usually seen in volume overload conditions like aortic regurgitation, mitral regurgitation, anemia, thyrotoxicosis, and patent ductus arteriosus. Sustained or heaving apical impulse. Sustained heaving or heaving apical impulse is seen in patients with pressure overload. That is because whenever there is obstruction to the outflow tract, so suppose there is outflow tract obstruction that occurs in aortic stenosis. So suppose the left ventricle is not able to empty it properly because of the obstruction at the aortic valve or through the coarctation of aorta. So what will happen is that now the ventricle has to eject blood against this resistance of the aortic stenosis. So it will take more time to empty. So that means that the contraction period of the heart will be of for larger duration. So that's why the apex impulse is both forceful and also it is last longer. So duration of the apical impulse is also felt for a longer duration of time. And definition wise, it is said that if apical impulse is felt for more than two-thirds of systole, then it is called as sustained or heaving apical impulse. This heaving apical impulse is also seen in hypertension because in hypertension patients, there is also peripheral vascular resistance is also high. So when peripheral vascular resistance is high, the aorta or ventricle will take more time to empty because of the resistance. It will take more time to empty completely. So that's why in hypertension also there is sustained or heaving apical impulse. Double apical impulse. Double apical impulse is seen in characteristically in hypertrophic cardiomyopathy. So usually apical impulse only during systole, only one apical impulse is felt at the chest wall. But in case of hypertrophic cardiomyopathy, what happens is that so now in hypertrophic cardiomyopathy, the muscle usually the basal septum is very much hypertrophy. You can see here this is the basal septum of the left ventricle. So this is the left ventricle, this is the left atrium, this is the aorta, and this is the aortic valve. So now what happens in early phase is that the ventricle will start contracting. So when it starts contracting and due to that contraction, the apex goes towards the chest wall and we feel the first apical impulse. But in hypertrophic cardiomyopathy, the apical impulse or this obstruction is dynamic. So what do you mean by dynamic is that now when the more contraction occurs, this septum goes more towards the aortic valve and it's try to block the aortic valve. So there will be some obstruction to the flow during the phase of systole. So initially, early contraction led to some apical impulse. Now there is some obstruction. Now to overcome this obstruction, the heart will contract more, give more contraction, and there will be more forceful contraction, which occur to empty this blood from the left ventricle into aorta. So during the rapid emptying, what will happen is that there will be another apical impulse which will be felt because of the second phase of contraction due to dynamic obstruction of the hypertrophic cardiomyopathy. Similarly, this type of apical impulse is also seen in left ventricular hypertrophy. So suppose a patient have a left ventricular hypertrophy. So similarly, if there is left ventricular hypertrophy, so what happens is due to this ventricular hypertrophy, there is in hypertension patient, there is diastolic dysfunction is present. That means that there will be impairment in the relaxation due to more and more stretch of the muscle due to blood pressure. So since there is impaired relaxation, so now suppose the atria wants to empty into the ventricle. This ventricle should be very compliant and should be able to take the blood. So suppose this ventricle is not compliant due to hypertension, what will happen is that when the atria is trying to empty into the ventricle, this ventricle is not stretching at all. So that means that it is not relaxing properly. So now, so this atrium will now, what will happen is there are four phases in diastole. That is, first is the isovolumetric relaxation. That means when this valve closes, that means this aortic valve closes, the ventricle will try to relax in this phase because the aortic valve is closed now. So once the pressure here in the left ventricle goes lesser to the left atrium, the mitral valve opens. So that is the second phase. And during this, there will be rapid ventricular filling. Third phase will be the diastasis, and the fourth phase is the atrial systole. So usually, majority of the atrial emptying occurs in the rapid ventricular filling phase. So since if there is diastolic dysfunction or impairment in relaxation, suppose there is relaxation defect, the blood is not able to empty in this rapid ventricular filling because this is passively blood flow here passively. in atrial systole. So now majority of the blood has to go out through the atrial systole. So in atrial systole, what will happen is that since the blood is not able to go passively fill inside the left ventricle, now the atria will contract very forcefully to send the blood inside the ventricle in this fourth phase of diastole. So when it contracts more blood goes into the ventricle and pushes the apex towards the chest wall, and there is another apical impulse felt. So this is double apical impulse, but there are one is in systolic phase because of the left ventricular contraction, and another is in the atrial phase, that is in the pre-systolic phase. It is called as atrial systole. This type of apical impulse is also seen in left bundle branch block, because in left bundle branch block, what happens is this is the left bundle branch you can see here. So the conduction goes slowly in this part and this part as well. So each part of the left ventricle is beating differently, and there is some lack of coordination here. So some part of ventricle may contract first, other part may contract first, leading to a double apical impulse. So similarly, we can also see triple apical impulse. Triple apical impulse means that there are three apical impulses felt during the palpation, and in this, two phases are in during systolic and one is during diastolic. So it is most commonly seen in hypertrophic obstructive cardiomyopathy. So as earlier discussed, in hypertrophic obstructive cardiomyopathy, the first apical impulse is because of the left ventricular contraction, which is routinely seen in all the patients because of the ventricular contraction systole. The apex moves towards the chest wall and first apical impulse is felt. Second apical impulse is because in hypertrophic cardiomyopathy, it is a dynamic obstruction. As soon as more blood empties, this septum goes more closer to this aortic valve and obstruct the left ventricular outflow tract. This leads to now to overcome this, there is second contraction, and thus there will be what will happen is second apical impulse will be felt. Also, in advanced stages of HOCM or hypertrophic obstructive cardiomyopathy, there will be diastolic dysfunction. So that means there is impairment in the relaxation of the ventricle here. So now the majority of the filling from the during diastole will occur in the pre-systolic phase, that is in the atrial systolic phase. So in atrial systole, what will happen is now blood will again push the blood inside the left ventricle in the forcefully during the fourth phase of diastole, and this blood will push towards the apex, and this apex will be felt now. So that's why there are three apical impulses which will be seen in HOCM. Also, this is also seen in severe aortic stenosis with left ventricular dysfunction. Suppose the patient has aortic stenosis with LV dysfunction. Now, what will happen is that the contraction is so slow. So initially, there will be some contraction, weak early contraction, which will lead to first apical impulse. Then there will be prolonged ejection. That will be second apical impulse. And also, what will happen is because in the severe aortic stenosis, the ventricle is very much stiff due to the pressure overload. And then the pre-systolic phase leads to the third apical impulse. Similarly, this can be also seen in severe left ventricular hypertrophy with a stiff ventricle. Next type is the absent apical impulse. It is seen in where there is apical impulse is not felt. So this is usually seen in patients who are obese. So because of the fat, the apical impulse is not felt. If suppose there is pericardial effusion, massive pericardial effusion across the heart, then also it will not be felt. In COPD, because of air trapping, the apex may not be very much visible. Other type is the retracting apical impulse. So usually during systole, apical impulse become prominent towards the apex or towards the chest wall. In retracting time, it's the reverse of that. There is inward movement of the apical region during systole. It is seen due to paradoxical movement due to restrictive pericardial conditions. What are the common causes of this are constrictive pericarditis and severe right ventricular overload. So we should also know RV apex, that is right ventricular apex versus left ventricular apex. What are the differential features? So location wise, left ventricular apex is usually felt at fifth intercostal space, midclavicular line. Right ventricular apex is felt usually at the left parasternal area. So we are talking about normal patients. So usually if the apex impulse of left ventricle is felt is usually localized. That means that the apex is localized to one part. Whereas right ventricle, so if we feel left ventricle, whenever this contracts, we feel only the apex part. However, in case of right ventricular enlargement, since the right ventricle, the whole base is felt over the chest wall. So that's why it is more diffuse. So left ventricle is localized, it is more diffused. And also, since this right ventricle, if suppose this right ventricle is enlarged, the enlargement goes in this direction towards outwards. So it does not go downwards. So there will be only outward movement and there will be no downward movements. And here, in case of LV apex, what will happen is whenever there is hypertrophy or enlargement, LV will go more both downwards as well as outwards. So you can see here. So generally displacement of left ventricle is usually both lateral and inferiorly, that is downward. Whereas in right ventricular apex bit, the movement is only leftward, that is outward. There is no downward movement. And duration is left ventricular apex is usually short, whereas right ventricular apex is usually sustained because the whole right ventricle is being felt and that's why it's more sustained. Also, the right ventricular character type is heaving type or lifting type, whereas left ventricular apex can be, depending upon the type, it can be either tapping, hyperdynamic, sustained, or heaving type. Thank you.